This conference will now be recorded.
Hello, everyone. My name is Jorge Cruz, and I'm the program manager at Doctors for Change. Today, we're having our very brief Q&A session and an overview of the opioid epidemic, which is in partnership with Baylor College of Medicine. Today, we have Dr. Alicia Kowalczyk, who's going to be doing a presentation and giving us an overview of the opioid epidemic. So I'm going to pass the mic over to you, Dr. Kowalczyk, to give us a brief introduction about who you are.
Oh, thank you, Jorge. So I'm Alicia, Dr. Kowalczyk. I'm an associate professor in the Department of Family and Community Medicine at Baylor College of Medicine, and I'm also board certified in addiction medicine. I work with Doctors for Change and the Houston and Harris County health departments on a grant-funded project to increase treatment for opiate use disorder availability in our community. That's part of the funding. And I'll be offering an Waiver primer for primary care clinicians who may be interested in starting this important work in their practice this coming Wednesday. So 2 nights from now from 6 to 8 p.m. and I hope to see you there.
Thank you so much. And if you are listening to this and are interested in registering, please visit our website at www.doctorsforchange.org, and you'll see one of our headlines there that says Waiver Training. Go ahead and click it. Registration will be available right there. All right, so we'll get started with the presentation.
Thanks, Jorge. So next slide. So we're going to describe the U.S. opioid use and overdose deaths data, the latest data from 2020. And discuss ways we can effectively address the epidemic in our Houston community. So how do we help people recover and sustain health? So we want to help people better address their pain. We know now that there's little role for opioids in treating chronic non-cancer pain, and that most acute pain episodes require a maximum of 3 to 7 days of opioid therapy for effective management if the pain is severe enough to require an opiate. It's really important to link those already with an opiate use disorder into treatment, especially medication treatment. We also want to prevent overdose fatalities and link people with opiate use disorder to care. So we want to make overdose prevention and response, including naloxone kits, readily available throughout our community, and also increase treatment resources within the community, which is what Wednesday night session is about.
Absolutely.
So this is the latest data from the National Survey of Drug Use and Health. This is funded through the Substance Abuse and Mental Health Service Association. It's a yearly data set. It usually comes out in September, October of the year. This just came out in the last couple weeks, and it looks at the previous year's data. So this is from calendar year 2020, really through much of the pandemic. And you can see this looks at the percent among in the past year among any users for different substances, and then the percent among total population. And you can see for these opioid substances that hydrocodone is still leading the pack. So these are commonly referred to as narcos or Vikes by patients, and then certainly street users as well. Then we see oxycodone, and then on down the line from there. Next slide. And where are people saying that they're getting their prescription pain relievers that they are misusing? You can see in this blue segment that it's prescribed by a single physician. So that makes up a large percentage, over 40%. But edging that out is given or bought or took from a friend or relative. We see a smaller proportion brought from a drug dealer or other stranger is down in green, and that's about 6%. And then some other way, this includes internet sourcing, etc., about 3%. So the vast majority are getting these substances from someone they know, whether it's their healthcare provider or a friend or relative. Next slide. Here's a different look at the data. So you can see that in 2020, there were almost 10 million people aged 12 or older in the US who misused opioids in the past year. You can see that the largest segment were using prescription pain relievers, so the vast majority. But there was a lot of overlap with those who use prescription pain relievers, misuse prescription pain relievers, and those that do a street product such as heroin, with many doing both in the same year. And this can represent people doing both at the same time, using them together, or transitioning from using one to the other, often transitioning from using pills to using heroin and other street products. Next slide. This looks like first-time use. So these are folks aged 12 and up who use these substances to get high for the first time in 2020. And you can see alcohol and cigarettes are pretty high, the legal stuff, and marijuana is edging up past cigarettes and is legal in some states. But I've really highlighted prescription pain reliever misuse and heroin misuse. So again, the opiates come right in, almost right behind marijuana, cigarettes, and alcohol. And then other prescription products that we might not think about as clinicians, but people are misusing: prescription tranquilizers, prescription stimulants, and prescription sedatives, things like benzodiazepines.
So this data here, is it data that's for Harris County specific, or is it for the overall United States?
Yeah, so this is for the whole United States.
Okay.
Next slide. So this is looking at treatment for substance use disorders. And these have not changed a lot over the years. We still see that in this pie chart, the vast majority, 97.5%, these are folks with a substance use disorder, didn't feel they needed treatment. Of those that felt they needed treatment, about 5.5% actually made an effort to get treatment, and the other, a little under 2% that felt they needed treatment, did not make an effort to get treatment. So we have a huge gap between those that need treatment and those who actually get linked into care, with many not even realizing that they need treatment. And this again is where primary care clinicians can have a big impact. Someone that might not acknowledge that they have a problem may be willing to talk to their primary care clinician about how to handle their escalating opioid use for their chronic pain in a way that doesn't force them to accept a label of a substance use disorder, and that can be really impactful. Primary care clinicians also see folks over time, and so can really help work with patients to increase their motivation to want to get treatment and seek treatment. These other charts really show the folks that, percent of folks that were getting any treatment. And so you can see all ages 12 and older, those 12 to 17, 18 to 25, or 25 and older, and how many are receiving treatment and how many are needing treatment still. Next slide.
Absolutely, and this really does show the big gap and where the need is within this gap for addressing this. So 37.5 million feel they do not need treatment, but that's, like you mentioned, the opportunity is there. The opportunity is there to help address.
So we're looking at opiate epidemic solutions. How do we get out of this? And it goes beyond opiates now. We're seeing a rise in stimulant use disorders, alcohol use disorders, but focusing on opiates because that is something that, you know, as clinicians, we can prescribe, and in some cases, you know, have, you know, it's been looked at that is our prescribing helping to kick off this opiate epidemic. although certainly at this point does not seem to be the primary driver of sustaining the epidemic, but we certainly want to do our part. So we want to be judicious with our opiate prescribing. We want to check the prescription drug monitoring databases. So we have a great PDMP here in Texas to check. We want to keep ourselves educated on the latest in chronic pain treatments and how to monitor our patients effectively if they do need opiates for their chronic pain, and also monitoring our own practices. We want to be able to do direct opioid overdose prevention. So clinicians, pharmacists, first responders, and public education are all key. As a clinician, if we're writing for an opiate, we should be co-prescribing naloxone. Naloxone distribution to lay and professional first responders is also important, as are appropriate prescription drug disposal and give back programs to just get more of these opiates off the streets and out of people's medicine cabinets when they don't need them and aren't using them anymore. We also want to provide intervention and linkage to treatment for people with opiate use disorders, real-time access to treatment, not I'm going to make this referral and someone will see you in 2 weeks or 3 weeks. And one way to do this is start doing this work in your own practice. We also, when we can, want to offer peer recovery support. That's really important in helping people initially engage with treatment and stay engaged in a recovery program. And then medications for opiate use disorder, also known as mood, include buprenorphine, methadone, naltrexone. 2 of these we can prescribe in primary care, and we should be learning how to do that. And so please join me on Wednesday evening for a relatively brief 2-hour session on how to get started with treating opiate use disorder in primary care. Next slide. And if we have anybody joining us, we'll do Q&A. Otherwise, Jorge, I'll turn it back over to you.
All right, perfect. Well, thank you so much for that overview. I don't believe we have anyone online, but we'll be publishing this online, so we'll be happy to just kind of go over some brief general Q&A questions. So the first thing that I wanted to talk about, just to kind of, again, just re-highlight that although this is a multifaceted approach to really just kind of doing what we can to address it here in Harris County, and we are reaching out to, physicians here in Harris County, and part of this, approach that we are taking is with our Max X Waiver training. And like Dr. Kowalczyk mentioned, part of that training, we are going to be talking about the medications for opioid use disorder, aka mood. And this will be something that we're going to be talking about. We totally would love everyone to join us to really learn about how to apply this to your practice. So my question that I just kind of want to just kind of discuss with you, Dr. Kowalczyk, is well, outside of what we're going to talk about Wednesday, what else can medical professionals do in their practice and also beyond to help address part of this, to be a part of the solution, really?
Yeah, so I think all of these things from, knowing when we're prescribing opiates, what we're prescribing them for, and being judicious with our opiate prescribing, being conscientious about co-prescribing naloxone when that's indicated, which is almost for every opiate script we write, particularly for chronic opioid scripts, and then seeking to learn more about how to provide actual treatment for opiate use disorder in practice, all very helpful. Other things for primary care clinicians to help with the opiate epidemic. One is addressing stigma. So even if you're not ready as a practice to take on doing this work directly, training staff and yourself to use non-stigmatizing language and to provide an office environment that supports people with substance use disorders in general, but opiate use disorders in particular, to want to come to the practice and be cared for and get their primary care needs met and not feel judged and stigmatized is really key. A lot of people who've tried to get treatment before or talk about this with maybe their primary care clinician have encountered stigma, and it makes them that much more reluctant to reach out and get help again. It's really important.
And I love that you mentioned that, because that's so true in things that go beyond also, what we're trying to address here, what we're trying to work together in with the opioid epidemic. Whenever someone goes to a medical, physician, if they feel that they're not comfortable speaking with the medical provider, then that kind of trust needs to be built. And I think that some patients may require a little more support to try to feel a lot more comfortable to discuss any health-related thing. So building trust, bringing that rapport with patients, I think is super key as well.
Definitely, definitely. Thank you for that question.
So in regards to now the Waiver training, right? So there's folks who are interested who, of course, may not be in Harris County. And I'd like to just kind of bring that up as a part of this conversation. So for someone who's interested in being part of this training, will they still be able to, to be a part of this effort in where they live to provide that sort of MAT waiver?
So they can definitely attend the training and, get what they need out of it. Our focus and our funding mandate is really on folks within Harris County, and we'll be doing follow-up and providing support services for those folks within the greater Houston area. But certainly anyone's welcome to attend the training. It's free, and take what they can from the training into their own communities. We need more of this work happening everywhere.
Absolutely. So now I want to put a spotlight on folks who are here in Harris County, who are practicing medicine in Harris County. So can you take me from A to Z, someone who joins this, actual training from point A to point Z, what does that look like for them?
So right now there are two ways to go about getting your X waiver to be able to prescribe buprenorphine in your primary care setting, which is the primary medication we use in primary clinical settings to treat opiate use disorder. And we'll detail that in the training on Wednesday. One involves getting the X waiver, just filling out some forms online, and then you can treat up to 30 patients in a given year with your X waiver. The other goes beyond just our 2-hour training this coming Wednesday, which will be enough to get you started. But if you want to go on and be able to prescribe to more than 30 patients at a time, you'll need to do an additional 8 hours of training. That's a nationally certified curriculum, and we're offering those sessions roughly twice a year. We don't have the next one scheduled yet, but it'll probably be coming up this winter. And then that will allow you to extend your practice a bit further.
Perfect. Thanks so much. And my last question that I think would be helpful to anyone who's listening is, what do these follow-ups consist of? Is it like how long does it take to be a part of this follow-up? Do I have to do a survey? Do I have to fill anything out? What does that look like?
Yeah, so we do ask you to complete a very short survey, about 2 minutes it should take at most to complete it. It's via email, you just click a link. And we're really just curious where you're at with getting started providing this care. Have you gone ahead with your X waiver or not? Have you gotten your X waiver, but you're kind of stuck on how do I get, my clinic up and running with this? And then we're certainly available if you want more intensive follow-up for us to, serve as a resource for you to get started, whether that's looking at helping you draft EHR templates for doing this work, or addressing other barriers within your system. So we're there to help as much as possible. At a minimum, it's a 2-minute survey about once a month for the first 6 months after your training. So it really is pretty minimal.
Super easy. Okay.
Mm-hmm.
Well, thank you so much, Dr. Kowalczyk, again, for giving us an overview and really just kind of breaking down some of the Q&As for the training. So again, it's this Wednesday, November 10th from 6 p.m. to 8 p.m. Central. If you would like to register, we highly urge you to. And feel free to share with your network as well. It's www.doctorsforchange.org. So please share, please join us, and we would love to have you out there. So thank you again. Any closing remarks or anything before we close out the session?
No, I just hope to see folks on Wednesday. Thank you so much.
Thank you so much as well.
Bye-bye.